This episode of The Next Breast Thing was made possible through the generous support of Myriad Oncology.
Myriad Oncology provides a portfolio of advanced genetic and tumor genomic testing solutions, including risk assessment, screening, tools to aid treatment guidance, and survivorship planning. The Myriad Oncology offering is designed to meet the unique needs of oncology specialists and their patients across each step in the patient care continuum.
To learn more, visit myriad.com/oncology.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
it was pretty fabulous, except for driving in at dark 30 and my husband being like, wait, this is someone's house that we're going to?
I got to meet 3 baby elephants at the zoo.
We've never announced the name of the baby cow, but the name that we have is... Today's topic is one that's central to everything we do as breast surgeons: patient risk evaluation and management.
Offering genetic screening for different types of things.
This is a whole group of patients that don't have cancer, and it's an opportunity for us.
And I was like, this is bonkers on here. And
what do you do with those patients that are 22% lifetime risk and say, you know what, I want a bilateral mastectomy?
None of us have a crystal ball.
What's the point of doing the 5 years of the endocrine therapy if we're not going to...
This is Carla,
Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Our topic today is patient risk evaluation and management. But before we get started, let's begin with some personal and professional updates. Susie, what's new with you?
So I got to do another off-the-grid experience. My family hates this every single time because they're so nervous. It's either a opportunity that we might be in true danger or we walk back really happy. My husband's face is seriously like grumpy pants on the way there, and on the way back is like a transformation of smiles. So we were able to go to someone else's house, and they had a lot of equipment at their house. We were able to use ATVs, UTVs that didn't have regulators, didn't have rules, and really like do a locals trip. And it was pretty fabulous, except for driving in at dark 30 and my husband being like, wait, this is someone's house that we're going to? Like, yeah, it's going to be great. So it was fantastic. Made some new friends, and it wasn't too touristy, so I got my cup filled that way too. Ellie, what's going on with you?
That's amazing. So I recently traveled back to the Midwest for 4th of July. I'm from Kansas originally. That's where I grew up. So I went there for 4th of July and saw my friends and family. And I got to meet 3 baby elephants at the zoo. They just had 3 babies, and it's one of the biggest herds of elephants in the country. I didn't know this, but for whatever reason, Wichita, Kansas Zoo is really up on their elephant herd, and they had 3 babies come at the same time. So I got to meet them, and it was one of the coolest things. So
so amazing. So I know that when giraffes have babies, the mom kicks them until they like walk and stuff. What happens with elephants?
So elephants do the same thing. And actually in this situation, 4 elephants were pregnant and one of them had a stillborn first. So it kind of like traumatized the rest of them. And so they were like really kicking the babies, and the vets were worried about it, but all the babies were fine. They ended up walking. But they were emphasizing the kicking part because apparently that's how they know that they're okay when they're born. So yeah, I learned a lot about elephant birth and some of their little rituals, but it was incredible to see the little babies running around and already playing. And it was truly one of those bucket list items.
Cool experience. And all I just think is for all those moms who are listening is like, whenever you think you're a bad mom and not good enough, just know that we're not kicking our kids.
Right.
Well,
It's in other ways.
don't let my wife listen to this. Yeah. I spent a year in Wichita 1 month. So, yeah,
Wait, I spent a year in Wichita 1 month. What do you mean?
it just was a long, it just,
Yeah, that's how I felt visiting. I was like, I don't know what I'm going to do here. So the elephants were a pleasant time for
value add.
value add. Yeah, Michael, what about you? What's new with you?
We got tremendous response from annual meeting, and we've never announced the name of the baby cow. It is a little concerning because a few months from now, I'm going to trade that baby cow off for another baby cow. So it kind of changes the gene pool a little bit. But the name that we have is Bovie.
Oh, I love that.
That's
so great.
that was the consensus name was Bovie.
Love that.
And I figure it wraps real with what we're doing. So there we go. Now, from here on out, baby cow's name is Bovie.
And for those of you who are not surgeons, a Bovie is an instrument we use on almost every single case in the operating room. So that's where that came from. That is so clever. It's
There's kind, yes. I didn't think of it. That's why it's clever. All right, let's move on to our topic. Today's topic is one that's central to everything we do as breast surgeons: patient risk evaluation and management. Whether we're discussing surgical options, imaging decisions, or long-term follow-up, understanding and managing risk is a constant part of our clinical judgment, decisions that sit at the crossroads of evidence, experience, and empathy. Susie, I want to start with you. You're a general surgeon. You're in a position that is different from some of the more academic places that have genetics departments and things along those lines. So how do you as a general surgeon incorporate risk evaluation and management in your private setting?
I love this conversation because even when patients come to me for other reasons, I'm able to look at family history and really just even see if their Trier-Cusick score that's on the radiology report actually makes sense. Because a lot of times, even when I go in, I fill that out. And some of those questions, if you don't quite know how to answer them, it might either increase your score or decrease your score, and use that opportunity. And I also use that opportunity. It might not have to do with breast, might have to do with colorectal and offering genetic screening for different types of things. So this is a really important part to my practice, and we really try to integrate it with, I won't say every patient. I mean, if someone comes in with an abscess on their bottom, I'm not going into this. But with other things that they come in for, we really try to delve an extra layer in there and see how we can help out. Ellie, what about you?
I often use it. I'm not expecting to use it. I'm seeing somebody for maybe a papilloma or nipple discharge, something like that. But then I notice on their form on the front there, it says they have 5 family members with breast cancer, ovarian cancer, some kind of cancer risk. So then I'm thumbing back through their mammogram report, like you mentioned, Susie, and seeing, their Trier-Cusick score maybe is a little elevated, and it allows me another touch point to get them maybe genetic testing, or we also have a high risk program set up at my hospital. So seeing if they're a candidate for that, it just gives me another tool in my tool belt to kind of look at the whole patient and address maybe another part of the visit that they didn't necessarily come in for, but is valuable to catch them and put them in that higher risk group.
Who manages the genetic testing or the genetic high risk clinic that you guys have?
I have a nurse practitioner running it at my current setting.
But she answers to you on that. So this is run through the surgery department?
Yes.
And does she run her own clinic and these patients are self-referred to her? Or how does she get?
Correct. So first they see the surgeon. The surgeon sees them initially, does the risk evaluation, talks to them, and the surgeon refers the patient to the nurse practitioner in her high-risk clinic, and then she operates that independently.
So who identifies them for you to see them the first time? Is this come from the imaging department?
The imaging department.
Okay.
Yep.
Okay.
Yep.
So,
Yep.
Susie, you have a different
Place.
setup?
Yeah, our setup's different. Imaging can do it, but primary care, I'm happy to take this off their plate. I think about a primary care visit. They've got 20 to 30 minutes to go through a lot of stuff. And this breast conversation, especially high-risk breast, is a 20 to 30-minute conversation to really go through it. And I think one of the important things that I emphasize is every time we meet, we need to reevaluate. Is this the right thing for the next year? Lining it up each time. But we put that through our clinic. Another option is through our oncology practice that we partner with. They can also go there. And the appointment is usually with me or one of my APPs. Any of the above is fine. We're all competent to do this. How does it work where you are, Michael?
Our clinic is a lot like Ellie's in the fact that we have an imaging department that looks at a Tyrer-Cuzick, flags that, and then they will refer those folks to either the surgeon or the high-risk clinic. And then we are in charge of that, like you are, Ellie, and oversee the nurse practitioner. It is a huge clinic and continues to grow. So if you're looking for opportunities within your practice to grow your practice, offering a high-risk clinic with a well-trained nurse practitioner is really a great opportunity. It gets patients in to see you, but you're really not having to see them a whole lot, and it really helps feed the imaging center as well. So this is a real value add to the whole process for the patient. You know, we're so used to taking care of patients with cancer. This is a whole group of patients that don't have cancer, and it's an opportunity for us. Susie, it sounds like yours is very similar as well.
Yeah, it is. And I also find, more importantly, that this is so important for the patients, either for awareness of saying, like, you may not have an abnormality in a gene, but you are at higher risk, and we just need to keep a closer eye on you. So let me take that burden on, and this is your schedule. In between these visits, you do your thing, and we're going to take this off. I think that is really important for the patients. And I also have people who come in who think they're high risk and they're really not. And I think that's also super important. And then that they are on a specific screening program as well.
Do any of y'all use Gale? Is it all Tyrer-Cuzick? Because sometimes when you run a Gale on a patient and then you run a Tyrer-Cuzick, these numbers are like not even on the same patient. How do you deal with that if you use Gale at all?
I don't use Gale anymore.
Yeah, I don't. In my residency, we did, but I don't in my current practice. We just do Tyrer-Cuzick.
Do you feel it overestimates risk a little bit?
LCIS for sure. Absolutely. And I think there's been recent literature out there, and it's really interesting. I had a patient last week where if I put in LCIS, which is an option, it was like a 48% risk of developing breast cancer in the next 10 years.
Right.
If I didn't have it, it was 17%. And I was like, this is bonkers on here, and really being able to take that. But I don't have a great model for LCIS. Do either of you?
No, I was actually just looking at the current ASBRS consensus guidelines that were just released and kind of brushing up on that and just looking at the rates. And it was saying, yeah, classic LCIS only has a 1% to 2% increased risk of breast cancer per year, which is very different than what some of these other models are saying. Obviously, if you have the pleomorphic type or the florid type, that's different. But the classic type, the Tyrer-Cuzick doesn't say that, does it? It just says LCIS. LCIS is tricky, the classic type. Which do we quote them? Is it the Tyrer-Cuzick model or is it those papers from ASBRS guidelines? I think I would go towards ASBRS guidelines, in my practice at least.
If you identify somebody that's high risk, who manages their endocrine therapy? Susie, do you send that patient on over to medical oncology, or are you managing that yourself?
In general, medical oncology, I have a phrase that I put in there, and I say these are pros and cons. And the STAR trial was really a amazing, powerful clinical trial. I actually worked on it prior to even going to medical school. And a lot of these preventive trials really didn't pan out, like across prostate cancer, about anything. And this was really powerful, but it does have risk associated with it. And it's a big discussion. If someone won't step foot into the oncology building because they have a different fear associated with that, I will prescribe it. But in general, I try to let them prescribe it. What about you?
We manage it ourselves, actually. And having the nurse practitioner deal with the side effects is glorious. It's hard to deal with all of that, and they do a really good job with it and they embrace it. What do you do in those situations where, we're basically considering a 20% lifetime risk, elevated risk. What do you do with those patients that are 22% lifetime risk and say, you know what, I want a bilateral mastectomy. I don't want to have to worry about that. Are you saying, okay, that sounds great, let's go ahead and do that? Are you forcing them, I say forcing them gently, into endocrine therapy? How do you guys deal with the situation of people that are by definition high risk, but there are varying risks as we clearly know? Ellie?
I offer them, first and foremost, increased screening. So I offer them biannual mammogram or MRI as kind of the first line of anybody over a 20% risk. That's the bare minimum that we're going to do. I also talk about those other things like the endocrine therapy. The risk-reducing mastectomy is another option, but I go through the very real side effects and long-term maintenance with all of those options. When I'm talking to the patient, seeing what their risk tolerance is, I go through kind of each of those situations and see which one fits best with them. Most of the time, unless they have a gene that's BRCA1 or BRCA2, I'm able to talk them into the higher risk screening versus doing any medication or additional surgery.
I agree. I feel that there's some people who are really convicted what they want before they step in your office. And I always ask, hey, what will you look back 5 years from now? Mm-hmm. And none of us have a crystal ball. But if you did high risk screening and it was caught early and it was a breast cancer and you still want a mastectomy, would that be okay with you? Or are you going to be someone who is so devastated that you didn't make this decision today that changes it? And I often say, let's get that MRI first and then let's come back and regroup. It is their body. They can choose to do it. There's not a perfect answer for it. And there's some people where they are so preoccupied with screening every 6 months that half of their year is gone. That's not worth it. And there's other people where some reassurance and taking that burden off of them, saying, I'm watching you, is just enough for them to allow it to go. And everybody's different. I say my own family, my mom and my sister might choose different things for that. Michael, how do you handle that?
That's a great point in the fact that we've got high-risk screening that we can provide people, but depending on their age, depending on what they're able to do, or depending on their finances, you're setting people up for a long-term surveillance that every 6 months or so, they've got to revisit this. And that's not my push for mastectomy, because honestly, I'm trying to dissuade that. But I think we have to take that into consideration of what we're asking people to endure when we put them on that screening schedule. Some people are very happy that they're being screened outside of just the regular annual recommendations. But others look at this as an ominous task that lies ahead of them, and they feel like they could just basically take that risk to zero, which we know they can't, but get it pretty close to zero with a bilateral mastectomy. So we're sort of torn between that, not wanting to do a mastectomy, but not subjecting them to this lifetime of every 6 months worrying about it and seeing what that's going to do. Now, the benefit of that I could see is if you do a course of endocrine therapy, is the ability to turn that off. I mean, I'll get patients that after 5 years of endocrine therapy, and I say, well, if the medication was effective like we feel that it was, you have reduced your risk to normal risk, and we can turn you back to annual screening. Is that something that you guys do, or how do you address that on the patients that have completed a 5-year course of preventative, so to speak, endocrine therapy?
Absolutely.
Yeah.
I mean, I think they need to graduate at some point, and I think it's important that we guide them in that direction and say, hey, look, for 5 years, we've done this every 6 months, and there's been nothing. I feel really comfortable about this. How do you feel? And walk with them through that.
Yeah. And I also think, what's the point of doing the 5 years of the endocrine therapy if we're not going to de-escalate something in some way? What have we traded here? Doing those 5 years of therapy, what are we gaining? And so, yes, we do the same thing in our practice. If they've done those 5 years of therapy, we will do maybe annual imaging instead of every 6 months, and maybe backing off.
Are both of you guys using MRI, or is anybody using contrast enhanced mammography for high-risk screening?
We use MRI at my current practice, and we actually just got breast CT, but we do not use contrast enhanced mammography. What about you guys?
I alternate mammogram with MRI. And we can do contrast enhanced, but we typically do the mammogram MRI. Michael, what about you?
Yeah, contrast enhanced mammography, I think, allows those situations, and we're kind of in it, but we don't have CEM, is that your magnet is really full. And we're getting a second magnet, but we have been referring patients outside of our institution for MRI. I wish that we would have instituted CEM, but sometimes those magnets are full, and I think it provides a decent option for folks. I mean, there's limitations to it, obviously. You're not seeing the axilla. Whatever's in the view of a regular mammogram is what you're going to see in CEM. But the specificity and sensitivity to MRI are pretty similar, and I think it's a viable option for high-risk patients. What are you guys doing now for genetic testing? Do you have a program set up for that? Who counsels that patient on doing the genetic testing?
For us, I do the counseling. I offer pre-genetic counseling through one of the providers. We used to have people on site, but I think genetic counselors have a lot of opportunities through industry that pay better, so we don't have them on site anymore. And I always reflex the positive testing to a genetic counselor that's board certified. I mean, I've gone through lots of courses, but I think when someone has trained dedicated to one thing, it's great to have that conversation with them.
Yeah, we do a similar thing, but we identify the patients for genetic testing. We make a referral, and we have a whole genetics clinic that's comprised of genetics counselors who do the majority of the going over the results with the patients and the genetic counseling. Obviously, if they need any kind of prophylactic surgery, then they're kicked back to us, and we take it from there as the surgeons. What about you, Michael?
Yeah, do they have the bandwidth for that? I mean, how many genetic counselors do you have?
We've got about 5.
Wow.
So it's been around, I think, for 15 years. So
that's amazing. What a gift.
That is amazing. We had 5 originally in our clinic, and we're now down to 1 off-site. Used to be, we would use the genetic counselors as a gatekeeper, and I think it really backed up the system. I think as we are testing more and more people, and as the public becomes more aware of it, we're doing a lot what you guys are doing is we're testing patients, and if they're positive or you wonder why on earth they're not positive, we'll refer those. And then it took a little bit of buy-in from our genetic counselor, but they realized that their time was much better spent dealing with somebody that they needed to deal with instead of the vast majority, which test and are negative, and we just move on. How are you guys dealing with VUSs? That's a interesting topic for variation of uncertain significance.
I love it. When I pre-counsel, I say, hey, it can come back positive. Even if it comes back negative, but you have a strong family history, there's something there. We're just not smart enough to know exactly what the name is. And the third category is a variant of unknown significance. And that means that there's something different about that gene because we're looking so carefully, but we don't know if it's related to cancer or not. And in most states, I think New York is one of the exceptions. In most labs, they'll continue to look at it. And twice in 14 years, I've had results come back. One person, no cancer risk, and I was able to call her. It was like 7 years after I'd done her genetic testing. And the other person needed colorectal cancer screening, colonoscopy every 5 years instead of every 10.
The reclassification rate is low, but it's not zero. It does raise a problem in that they will send that information back to you, but if you're old like me and retire soon, what's the touch point for that patient? And that's an interesting question that's out there. Ellie, do you have a way of dealing with a situation like that? I mean, you're young, you're not going to retire for 30 years, but what's the situation for that?
This actually was brought up at our tumor board a couple weeks ago because exactly this happened. A retired physician had ordered genetic testing on somebody. The genetic testing came back after the person had retired. It kind of got lost in the shuffle. And then the patient represented to my hospital, got diagnosed with cancer, and they said, okay, where's that genetic testing? And after they went down a bit of a rabbit hole, they found this testing that had been updated but not informed of the patient. I mean, it was a mess. And so our question at the tumor board was asking the genetics company, you guys need to inform the patient. If there's a change, you can't necessarily rely on the doctor. You need to be informing the patient. That's your responsibility to let them know.
It's interesting because I feel like they do have that endpoint and they do inform the patients. It's hard when it was maybe 10, 15 years ago because the patients maybe didn't have the same email or whatever.
Right.
But right now they have to set up their own portal, and sometimes the patients get the results at a similar time frame that I do. So I trust that that's improving over time. I also trust as more of us are in electronic medical records that it gets scanned in the right place and someone has to access it. So I'm hoping going forward that is going to be smoother.
Most of them do have a portal for that. It just does take the patient to go in and give their information. I agree. People move so much more now than they used to, and relying that the individual physician is going to be in practice or whatever going forward, it really does need to go back to the patient because there's multiple companies that are offering genetic testing. Do we just assume that the results you get are all the same? Well, that's controversial. I'll throw that out.
Not at all. So as a general surgeon, and I also do a lot of wound care, I actually at one point had a rep chart up in our office. And so it has to be, what's the product worthiness? Is it good? Is it adding to the space? What's good about it? Then it has to be, what's their literature behind it? Because we do want to know, do they have more variant of uncertain significance than other companies? We don't want to be caught in that. We want to have people who have good, solid data. And for me, the rep does matter because if they're equal, I'm going to pick who I like better, who's easier to work with, who's not chasing me around at all times, who trusts me to do the right thing and provides me with really good education for the patients. So those are the three things I look at. Product worthiness, what is their company's research compared to others? And it has to be good data. And do they really have a robust company? I guess my fourth thing is it paid for, and how is insurance really working with that company? Because you don't want to have someone slapped with a big bill. I want to be able to comfortably say, hey, look, if your insurance doesn't pay for this, they should, according to my calculations. But if they don't, your max out of pocket is $250. Is that okay with you? And if it's not, then we can have a different conversation. But those are my four categories. What about you all?
I've honestly never had the choice between companies. It's all been set up for me. So I'm certainly not aware of anything different than what my hospital has. What about you, Michael?
Yeah, it's interesting. With one particular company, we had set up a really nice program where we could walk out of the room and we could set up a video conference and they would discuss with patients the risk of it. So I'm not even in there particularly other than just my cursory discussion. And then we could come back in and ask if they had any questions. And I thought it was a great system. Oddly, we lost our rep. And unbeknownst to me, the high-risk nurse practitioner flipped over to a different company just based on not having a rep. And so you see, wow, you don't have any more control over than that. Well, you've got to kind of keep tabs on what's happening in your high-risk clinic, that if you've got a thing that you think works for you and to have a good program going, that some of those points that Susie mentioned can be game killers to your program because they don't feel supported or they don't feel like that they're getting the right information. Nobody wants a rep in their office every day, but the rep support is a big piece of this in a busy practice.
It is really important. And I think one of the biggest things is sometimes patients will get an EOB that shows that they have a really big bill coming and they can call and they freak out. And I would too if I got that, and being able to say, no, look, I will have them call you and walk you through this. And if the bill is in fact larger than that, they will take care of it. And I think it is really important you have that relationship and you can look someone in the eye and trust that that's what's going to happen.
What do you see on the horizon for risk evaluation? I know some companies have products where they can actually stratify risk even among genetic mutations. What are your thoughts on that?
I don't use it at all. I really want to be patient focused. I have some people with genetic mutations that may increase their risk of developing breast cancer in the future by 30%. They're 100% comfortable screening. And I have other people that is 30% too much. I think that's really important to have that discussion with the patient. Where I'm seeing this going in the future is breast density, even when it's not related to a score greater than 20%, how to screen them appropriately.
I agree kind of with what Susie says. The density part, that really seems to be the subset of patients who feel like they're kind of being left out in the middle. They don't have the higher Tyrer-Cuzick score. They don't have the family history. They're supposed to get their mammograms at 40, but they're usually having to advocate for themselves for that imaging. So I'm hopeful that there will be some progress in that part of our guidelines and thinking of people's risk, because the fact that we can't see through their breasts on mammograms is a big deal, and we need to do better for those people. So I'm right there with you, Susie. I think that's kind of the future frontier of catching those patients before cancer. What about you, Michael?
I think that actual genetics is going to help us a lot with that. I totally agree with you. The ACR has recently strongly encouraged MRI, which is going to boost the magnet use for those dense breast patients. Also, more and more opportunities to look at dynamic imaging, and that's going to help us as well. We're going to need to wrap, so let's just kind of go back through. We're going to start with Susie. What have you taken away from today's episode?
I am really excited about today's episode because it sounds like coast to coast. There's a lot of things we do similarly, and that makes me excited.
Ellie.
This is an important subset of patients, these ones that we're grabbing before they have cancer. And I think it's really important that we look at kind of the ways that different places have this set up, to have the genetics, to have the score set up in the mammograms and stuff like that. These are ways that people can build out these programs. And like you mentioned, Michael, creating a high-risk program is a really great thing to do at a new hospital, especially if you're starting a new job. For those people starting their careers, that's a good ticket for you to really build something.
I think as time changes, we're doing less and less surgery, and we need opportunities to maybe even address patients before they've got cancer. This is kind of the beginning push of preventative medicine, and I'm excited how this can sort of serve up for the future. So, to our listeners throughout the breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.